all works well, and I have a chance to go over them with you a little bit. And you had a nice breakfast, I hope. All right, well, we're off to a great start. I just can't tell you how much I enjoyed Dr. Domini's talk last night. I look forward to what he has to say today, as well as the other speakers. It's kind of a special weekend for me this weekend. I have a chance to have representatives of three of my mentors here. Three of the people that made all the difference in my life, and I'll speak more about these people as we go on today. But I just want to introduce you to the fact that there are many people, and they happen to be all men. That's not my fault, but it happen to be all men whose shoulders I stand on. And the legacy of these very famous men, their representatives are here. Dr. Kempner is represented by Robert Rosati. And you'll have a chance to meet him. That's the rice diet. Dr. Vogel will represent Dr. Nathan Pritikin, and Dennis Bourdette will talk to you about another one of my very important mentors, which is Roy Swank. And so it's a special weekend for me this weekend to have these three men here to present to you the work of three people that have made all the difference in my life. Without them, I wouldn't be here now. I wouldn't have the opportunity to speak to you as I do. And especially with the confidence that I speak to you, because I have literally a half a century of people's work to confirm what I tell you is true, without any doubt. So today is going to represent those kinds of presentations for you and for me. That's why I'm so excited about what we're going to hear today. I am asked to give a presentation November 19th up in Portland to a group of physicians. And when I do this, I have to put together presentations with certain rules. And so what I've decided to do this morning is to give you that presentation, first time ever. And hopefully you can help me work out some of the bugs so that when I present it on November 19th, it'll seem smooth. And of course, my son and daughter-in-law are sitting back there with pen and pencil to make sure that all the things that I say are correct and properly referenced in the scientific literature. What I've been asked to talk about, this is a conference on diabetes, I've been asked to talk about the issues of diet and diabetes. To begin, I must make disclosures as to my potential conflicts. And there are potential conflicts, as any good presenter would do, as they would tell you, as Dr. Domini did last night, potential conflicts so that you can see where the presenter's point of view may be coming from and what biases may be affecting that person speaking. And so I do have some conflicts of interest. I run this center. This is how I make my living. Running weekend programs, Costa Rica trips, 10-day live-in programs. But you know what? I have no trouble looking at myself in the mirror every morning. I love my work, and I feel very good about what I do. And your feedback, of course, reaffirms for me that what I do is the right thing. We have a company called Dr. McDougall's Right Foods. I don't own it anymore, but we're sold in over 6,000 stores across the country. Some of you are familiar with those products. We run the adventure trips. I have 11 national best-selling books. The 12th one will be coming out in May of this following year. And I'm also on the scientific advisory board of Whole Foods. All this started, as far as my life in medicine and diet, all started when I was a plantation doctor back between 1973 and 1976. Mary and I moved to Oahu, Hawaii. In 1972, I was an intern there for a year. Between 1973 and 1976, I took care of 5,000 sugar plantation workers. The children, the old people, the wives, the husbands, 5,000 plantation workers, and I took care of all their problems from birth to death. I caught 100 babies. I'm sure I pronounced 100 people dead during that experience. I learned two things. I learned what my limitations were as a physician, and I learned the importance of good diet. My plantation patients were first, second, third, and fourth generation Filipinos, Japanese, Chinese, and Koreans. My first generation patients who were from Japan, China, Korea, the Philippines, they learned a diet of rice and vegetables. And they maintained that diet because that's what they learned as children. Their children, however, they were a little bit more westernized. They didn't have McDonald's there. In fact, the first McDonald's arrived in 1974 in Hilo, Hawaii. This was on the Big Island, Hilo, Hawaii, and I was their first customer and one of their best customers. But they were influenced by Western eating by places like Texas Drive-In. And as they became more influenced by the good old Western diet, they became fatter and sicker. And by the time I got to the third generation, they were fully Americanized and they looked it. And their health represented it. They were fat and sick just like everybody else. So that was my primary lesson on the dietary treatment of disease. Came from my patients. I learned basically everything from my patients. This is a picture of Heather, who's sitting in the back of the room. It's my son Patrick, who will be here a little bit later. And it's my best friend, Dr. Schrader, who actually invited me to this talk in November. And of course, this is me doing one foolish thing, riding on a motorcycle. I don't take those kind of risks anymore. Let's talk about diabetes. Diabetes is a disease of obesity. Obesity, it is, they're equivalent. As you get fatter, you get sicker, and one of the expressions of sickness is diabetes, type 2 diabetes. Unless I qualify otherwise, this entire presentation is about type 2 diabetes, not type 1 or childhood diabetes. And so if you are obese, your chance of becoming diabetic is 40 times greater than if you were, say, thin. The fatter you are, the more likely you are to become diabetic. There have been multiple trials done, and here's a list of 5 of these trials where they've taken people and they've given them advice, like to eat healthier, and that's been primarily to eat low-fat, high-fiber, less oil, less meat, less dairy, more vegetable diets, and to get some exercise, to lose some weight. And each and every one of those studies has shown that if you take these preemptive steps and you get people to become healthier, that in the future they have less risk of having diabetes. Once people become diabetic, you can get them cured easily just by causing them to lose weight. That's how close the correlation is between obesity and diabetes. If you just get people to lose weight, like for example, if you operate on them, you do bariatric surgery, lap band surgery, gastric bypass surgery, you cause a sickness and malabsorption in people so they have to lose weight, or at least that's what they're supposed to do, then you find that you cure type 2 diabetes. You get complete resolution in almost 80% of the people who are type 2 diabetic just by doing these kinds of surgeries and forcing them through sickness and malabsorption to lose weight. You can also get people to cure their diabetes by going on a low-carb, high-protein, high-fat, Atkins kind of diet. And you can cure their diabetes. Not only does their diabetes get better, but their blood pressure gets better, their cholesterol gets better, their triglycerides get lower, and they're declared healthier by going on a diet of meat and butter and cheese. But these same kind of low carbohydrate diets, when you look at them from a more general point of view, you find that they actually cause type 2 diabetes. Multiple studies have shown this, and meat is probably one of the biggest culprits when it comes to causing type 2 diabetes. And these low carb, high-fat, high-protein Atkins kinds of diets, they're centered around meat. Now, I'm sure all of you have thought to yourselves, how can a diet of meat, of lunch meats, of butter, of cheese be healthy? It just doesn't make any sense. Well, probably the most important thing to understand when you feed these kinds of diets, these low-carb Atkins kind of diets, and cause weight loss and cause these signs of poor health, like elevated blood sugar, blood pressure, cholesterol, to improve, the end point, the ultimate outcome of these kinds of diets is one that is not favorable. And this has been looked at carefully, and it's been found that when your friends, your relatives, lose weight, and they do temporarily, it's always temporarily, it's never long-term or rarely long-term, when they lose weight temporarily by eating a diet of meat and butter and cheese, the outcome is as expected. They have a higher risk of dying. Now, there was a study published in Mayo Clinic Proceedings back in 2003. And this study talked about how when they put people on a low-carb, Atkins kind of diet, lots of meat, butter, cheese, when I put them on this kind of diet, what happened is not only did they lose some weight, not a lot, maybe 6 pounds, maybe at best 10 pounds, they lost some weight. And associated with that weight loss is a drop in cholesterol and triglycerides and uric acid and blood pressure. And as a consequence of these changes in risk factors, these numbers that we all focus on so much, the doctors declared the patients healthier. And so I wrote a letter to Mayo Clinic Proceedings about my assessment of what really went on. I said, signs of improved health appear to accrue as measured by changes in a variety of risk factors: cholesterol, triglycerides, uric acid, glucose, blood pressure, and body weight. Hence, the patient is declared healthier. However, this is not necessarily a correct assessment. Similar benefits, for similar reasons, are seen when patients undergo cancer chemotherapy. And physicians do not brag about these results. You see, the way these diets work is they make you sick. I can give you CMF, cytoxin, methotrexate, and 5-fluorouracil, which is the treatment I was taught to give patients with breast cancer. And their cholesterol goes down, and their blood pressure goes down, and they lose weight. You think that has any chance of becoming a new national weight loss program? Well, people take shots of horse urine and do all kinds of other bizarre things, so why not? All right, you can lose weight by being healthier. We've looked at a lot of patients. We're in the process right now of looking at 2,000 patients. But previously, we looked at large numbers of patients. For example, in this research, we're looking at 1,250 people. And this is an 11-day span of time, and what we find is that the weight loss for all people is 3.6 pounds. With unrestrained eating, okay, you eat ad libitum, as much as you want. The food is served buffet style like you've been fed this weekend. And with those kinds of rules, what happens is the average weight loss is 3.6 pounds. If you start really overweight, say over 200 pounds, the average weight loss is 5.3 pounds. So about a half a pound a day. That's pretty reasonable. And that's for men, and for women, a little less. Women have a little more slow weight loss than men do for a variety of reasons. But about 3 pounds for women and about 4 pounds for overweight women. That's the weight loss you get by eating a healthy diet. As far as long-term, I had an opportunity to study long-term weight losses in a group of patients that I took care of several years back in Minneapolis. These were employees of Blue Cross Blue Shield health insurance company. And I was given the opportunity to take care of their employees for 3 years. We took care of 3 groups of people, so we had a chance to measure their long-term weight losses. Now, the benefits for these people were the same as we get in our 10-day program here or the 12-day program I ran at St. Helena Hospital for 16 years. Same results. They're reproducible in any city, in any country, in any part of the world. And what we found is that people lost weight initially as expected. Their cholesterols went down about 30 points. They felt better. They got off their medications. And the interesting thing about this particular project was we had a chance to measure their health care costs. And what we found based on the claims data for Blue Cross Blue Shield is that we were able to cause a 44% reduction in health care costs with this kind of dietary change. Long-term weight loss, well, in compliant people, the long-term results were a 17% drop in weight, which is about a 36-pound weight loss on average in these people. Some of the people who follow a starch-based diet ad libitum, that means you eat as much as you want, which is how you eat anyways, right? Sure, eat as much as you want. These are typical examples of people who take me seriously. You know, you see those advertisements on Jenny Craig or Weight Watchers, and they show you this wonderful example, and they always have this disclaimer. These are the best case scenarios. Do not expect these results. You should expect these results. If you make these changes, this is what will happen to you. This is as closely tied to health as a half a bottle of whiskey is tied to a hangover. You know. Anyways, these are some of the people that have taken me serious over the years. This lady in 10 months, she went from 210 to 120 pounds, dropped her blood pressure. She became what some people would consider mildly diabetic or pre-diabetic to normal, dropped her cholesterol significantly. Another one of our patients who lost 150 pounds, took her 10 years, but she kept at it because she knew it was the truth. I'm not trying to tell you this is the easiest thing in the world to do. And learning how to eat well and to take good care of yourself takes some effort. But once you do it, and I know many of you have accomplished this, you look around and you say, well, why doesn't everybody do this? This is so stupid simple. You know, how can you miss this? Because the learning curve is a little steep, it's harder for many people to do it. The learning curve for a low-carb High-fat diet's easy. You just drive through the fast food restaurant line and you order your meal, throw away the bun, scrape off the ketchup and pickle, and you're on the Atkins diet. What could be easier, right? But when people keep at it, what happens is they lose weight. She was at it for 10 years. It took her 4 years to lose 150 pounds. This man, and all of you who are on my discussion board are familiar with many of these people because they're active participants. This man went from 331 to 165 pounds in 2 years, dropped his cholesterol, feels phenomenal to say the least. And another example, 110 pounds. Why would you expect otherwise? There are no fat Chinese living on rice-based diets, are there? I mean, there are 2 billion people, 2 billion Asians who live primarily on starch-based rice diets. And is anybody obese? Nobody. I mean, I have folks like yourselves who visit China and Japan and Thailand and Cambodia and so on. You walk around the streets, you don't see any fat people at all, ever. Well, now you do. But that's because the diet's changing. So this is a fundamental truth that it always works. And 149 pounds for this woman. It took her 4 years. 149, well, that's not bad. But she's permanently healthy. Yeah. And in the process, dropped her blood pressure and cholesterol, as you would expect. And this woman right here came to us to Costa Rica a couple of years ago. She says, it's been a long time since I liked a picture of myself. She says, no, I can't pick one I like. They all look good. Yeah, she really likes the way she looks. As you all should too. It's just a matter of changing the fuel, that's all it is. And one of our long-term participants took her 7 years, lost 100 pounds permanently, but this happened 10 years ago. Dropped her cholesterol in half, blood sugar in half, dropped her blood pressure. This is what you should expect, because you fix the problem. Fix the problem. As we learned last night, the human diet, what do we call it, starchivores? Human beings are starchivores. You are a starch eater. Till you figure that out, life will be difficult. Once you figure it out, everything becomes easy. All right, what causes diabetes? Well, first of all, there are 2 kinds of diabetes. There's type 1 and type 2. Different diseases, but they share the fact that the blood sugar goes up in both. Type 1 diabetes is due to the destruction of the pancreas. We often call this childhood kind of diabetes because it used to be the most common kind of diabetes in children. Now, because children are so fat, I mean, 30% of them are overweight and a good share of them are obese. Type 2 diabetes has become very common. So we can't really call it childhood kind of diabetes anymore because there's just so much type 2 diabetes among children. But traditionally, type 1 diabetes, it's the kind where the pancreas gets destroyed. It gets destroyed as a consequence of an autoimmune reaction. And I believe the bulk of the scientific literature points the guilty finger at dairy products as the initiator of this autoimmune reaction. You can read the research yourself. Type 2 diabetes, however, is different. Type 2 diabetes, the body makes lots of insulin. Type 1, the pancreas has been destroyed, and the pancreas can't make insulin, so you have an insulin insufficiency. But in type 2 diabetes, you got loads of insulin in the body. In fact, you often have twice as much insulin as somebody without diabetes. Just the insulin doesn't work. It has become ineffective. The body's developed insulin resistance. And one of the first clues as to the cause of type 2 diabetes occurred under a national worldwide crisis. And that was during World War II and World War I. 2 crises in the last 100 plus years. What we saw during these wars, here you have 1905, 1920, all the way up here to 1950. And what you find is the mortality of type 2 diabetes prior to World War I is increasing. The war years hit, and in Western Europe, what happened is the incidence, the mortality, and the incidence of type 2 diabetes plummeted. Now, I want to mention, along with the decrease in incidence of type 2 diabetes and death from type 2 diabetes, heart disease almost vanished. People with multiple sclerosis, well, we know this for World War II. People with multiple sclerosis stopped having attacks, and new attacks stopped occurring. People who had diabetes, they stopped having complications. In other words, a time of tremendous stress during our major wars, World War I and World War II, people became healthier. And the reason, of course, is because of the change in diet that was forced upon people in Western Europe. So we come up here, post-World War I years, the good times returned. People were able to eat more meat, butter, cheese, etc. Then World War II came along. We have 1939, and precipitously the diseases that are killing your friends and relatives dropped in times of tremendous stress. And that was because of the change in diet. Of course, we see the change in diet. This is looking at mortality in women during the years between 1939 and 1947, drop in mortality. You see the changes in calories. This is the increase in carbohydrate that occurred, decrease in calories that occurred, and dramatic decrease in fat that occurred during the war years. So that was one of our first clues as to what causes heart disease, type 2 diabetes, multiple sclerosis, and the other common diseases that afflict your friends and relatives and neighbors. Studies have looked at the chance of people getting diabetes based upon how they live and what they eat. And our very important presenter tomorrow, Dr. Neil Bernard, will be here to talk to you about something other than diabetes. But I'm sure if questions come up, he'll answer them for you. He's done some work and published it in our scientific journals that tell us that but depending on how you eat, it depends upon your chances of getting diabetes. For example, if you eat the typical Western diet, your chance of getting diabetes is about 8%. Yeah, about 8%. And by the way, that's a figure that's rapidly changing. The estimates are that in the next 20 to 30 years, 30% of the population in this country will have type 2 diabetes. So if you are semi-vegetarian, your chance of getting diabetes is less. Pesco-vegetarian, that's kind of an oxymoron, I guess. That means you eat fish. You're a vegetarian. Lacto-ovo-vegetarian, and further reduction. If you're vegan, you have the least chance of getting type 2 diabetes. And some of you have heard my talk about the fat vegan. Being a vegan doesn't necessarily mean you're healthy. It's very easy to be a fat vegan, and of course, fat equates to diabetes, type 2 diabetes. And the various studies, and these amount in the hundreds of studies that have been done over the years, what we find is the correlation between diet and diabetes rests upon various components. I don't think it's really right to talk to you about the components because it presents an artificial picture. For me to talk to you about a high-fat, low-carb, low-fiber, high-protein, I mean, those terms are interesting and scientific. The major way of thinking of this is the kind of diet that induces diabetes is one high in animal products, high in meats, high in poultry, high in fish, high in cheeses. That's the kind of diet. And those foods I just mentioned are high cholesterol, high fat, low carbohydrate. But it's better to think of them in terms of the foods. The same thing with the other side of the coin, and that is that a low fat, high carbohydrate, high fiber diet is really a starch-based diet. So don't let me confuse you with these terms that take the focus off what's really important, which is the real food on your plate. The kinds of foods that cause type 2 diabetes are the meats and cheeses. The kinds of foods that prevent type 2 diabetes are the potatoes, rice, corn, and so on. So you look at the individual components. You want to reduce your risk of diabetes, high fiber diet. Fiber is only present in plants. No fiber in any animal food. Lower glycemic index, well, the lowest glycemic index are animal foods, but I can't go into that in some detail. Less sugar, more beans, that means less diabetes. Less total fat, fewer eggs, fewer meats, less processed meat, and there's an association between more good fats. But of course, good fats, your omega-3 and omega-6 fats are made by plants. Yeah, you know, fish get them, but they get them because they eat plants. The basic research that tells us what caused type 2 diabetes was published by Shirley Sweeney in 1927. And of course, he had his mentors. He had people that preceded him that did the work that led up to this. But what Shirley Sweeney did is he took his medical students. Medical students were always eager to volunteer for experiments. And he took his medical students and he fed them a high carbohydrate diet. This is the blood sugar levels that are going here from, this is 100, 120, 140, 160, 180. Above 140, most people would diagnose diabetes, 140 blood sugar. Some people call pre-diabetes anything over 100. And there are many doctors out there that treat people with blood sugars 120, 130 with diabetic pills. But I think an agreement we could all make is that if your blood sugar is over 140, then you have type 2 diabetes. That's the diagnosis. So he fed these students of his, he fed them sugar and candy and white bread and pasta and potatoes and bananas and syrup and a very, very high sugar, high simple carbohydrate diet. And they all tested non-diabetic. And then he fed them a diet high in protein, and the blood sugars here are coming up in the 140, 160, 180 range. And they tested a mildly diabetic, high protein. That means lean meats, whites of eggs. And then he fed them a high-fat diet. That's olive oil, you know, that good fat. Butter, mayonnaise, egg yolks. And every single one of his students became diabetic. In fact, some severely diabetic. We knew that in 1927. He took one student and just compared the effects of blood sugar of one student, and he found that student, here's a blood sugar of 200. That student on a high-fat diet was diabetic, on a high-carbohydrate diet. The ones I just described to you was non-diabetic. And so what people knew in the 1920s was that fat somehow paralyzes insulin activity. And carbohydrate, even sugar, seems to make insulin work well. And that was all brought together in a very important experiment that was published in the New England Journal of Medicine in 1971 by Brunzell. And what he did is he took people who were mildly diabetic and he changed them from a diet that was 45% sugar to 85% sugar, simple sugars. And what he found is the fasting blood sugar fell, the overall glucose tolerance improved, the fasting insulin levels were lower. Here they are, here's insulin levels. On this high sugar, twice the amount of sugar, on this very high carbohydrate diet, the insulin levels were lower as opposed to on a lower sugar diet. Same thing with your blood sugar levels. On a high carbohydrate, 85% sugar, the blood sugar levels were lower. Hey, that doesn't make any sense, does it? Well, it doesn't make any sense until you realize the conclusion of these researchers, and that is this data suggests that a high carbohydrate diet increased the sensitivity of peripheral tissues to insulin. Sugar makes insulin work better. Fat paralyzes insulin. If you understand that, then everything else makes a lot of sense to you. Of course, you know, everybody else has it the other way, don't they? Yeah, don't eat sugar, it'll make you diabetic. Well, with that kind of thinking, what happens is all diabetics are guaranteed to remain diabetic. They'll never get better. That's the kind of thinking that's taught by most doctors, diabetologists, and other experts. And what's the result? Nobody gets well because they're working under the wrong set of rules. Peripheral resistance to insulin, insulin resistance. This is the whole underlying theory as to how you develop type 2 diabetes. Remember, type 1 diabetes, you have an insulin problem because the pancreas doesn't make insulin. And insulin acts as a key that opens the cells that allow sugar into the cells. If you don't have that key to open the cell wall or allow sugar into the cells, what happens is your cells literally starve to death. And the sugar remains outside the cells and in the blood, and as a result, you have a high blood sugar. Well, if you don't have sufficient insulin produced by the pancreas, you have type 1 diabetes. But what if you have lots of insulin made by the pancreas and you still have an elevated blood sugar? The problem there is insulin resistance. The cells are resistant to allowing sugar to come in. They're resistant to the activity of insulin. Insulin becomes ineffective, even though it's there. It's present in the blood, it's present in the body. It's just that the cells are no longer responding to it as the way it should. And we see with this insulin resistance, we see accumulation of fat in various tissues, in muscles, and liver, and pancreas, and all over the body fat accumulates. Insulin resistance. Now, why does insulin resistance occur? People think this is a disease. This is not a disease. This is a normal adaptation that takes place by the body to save itself. That's why it develops insulin resistance. What happens is, I see it as this, is we eat this rich diet, all of these foods for kings and queens. As a consequence of eating all this rich food, what happens is we get fatter. But getting fatter was okay once upon a time, when getting fatter meant preparing for the famine that was about to occur, or the long, hard winter where not much food would be available. That was okay in the summer and the fall, take in a little extra food, put on a little fat, maybe find yourself an animal to kill, and over the next day, probably a day, no refrigeration, probably a day before it rotted, you were able to take in some extra animal fat, put it in a little extra body fat. So that was good, because when the famine came and the fall and the winter came, you'd have a better chance of surviving. There wasn't a lot of rich food. It was tough to kill an animal. Certainly you couldn't store it. So it was limited the amount of extra fat that you could put on. But in our good times, or whenever people became rich, whether it was 3,000 years ago as pharaohs and queens, or 300 years ago as the aristocracy of Western Europe, or today, as every American knows, to eat like a king and a queen. When you have all this rich food, it's forever, never ending. What happens is you start putting on the fat, getting ready for winter, right? Yeah. And you put on 30 pounds. The body says that's good. You'll make it through the famine. 30 pounds, just fine. But you keep eating. And pretty soon you're up to 50 pounds. The body says, you know, this may not be such a good idea. You keep doing this and we're going to get into a survival problem. You're not going to be able to outrun the enemy. You're not going to be able to climb the tree. And you gain another 50 pounds, you're not going to be able to fit through the cave entrance. So the body says there's a problem. We need to make a normal adaptation. This is not a disease. This is a normal adaptation. And what it does is it becomes resistant to the effects of insulin. And in addition to insulin's job being to open the cells, the normal cells, so the sugar can get in to provide energy, the other job of insulin is to allow fat to get into your body fat cells so you can store the fat for that famine. Well, the body says, hey, you stored enough fat. I don't want you to let more fat into the fat cells, so I'm going to cause the insulin to be more inefficient, less effective. We're going to develop insulin resistance so that you don't end up killing yourself by becoming morbidly obese. So what do you see typically a type 2 diabetic? They're 60 pounds, 50 pounds, maybe 80 pounds overweight, but they're not really, really huge. No, not really huge. Now, those of you who are doctors, you stop and think about it for a minute. You've taken care of some really big people. I've taken care of people that have been 500, 600 pounds. And you look at these people, I'm talking about a 5'5" man that's 500 pounds. And your initial thought is, boy, this person must be in horrible shape. They must have terrible diabetes, terrible cholesterol, terrible blood vessels, terrible high blood pressure. And you closely examine them, what you find is they don't have any of these. Sure, they're morbidly obese, and their lower extremities are suffering terribly because of all that weight. But they're not diabetic. They don't have high cholesterol, and their arteries are clean. What's happened with these people? What's happened is this: these people don't develop insulin resistance. They don't go through that normal adaptation. So as a result, that insulin keeps working and working and working and stuffing that fat in there. 100 pounds, 200 pounds, 300 pounds. But because they don't develop insulin resistance, they don't develop the other adverse effects that we see associated with diabetes. High insulin levels are associated with more atherosclerosis, more high blood pressure, more other problems. Well, these people are different. They don't become insulin resistant. They don't go through that normal adaptation like most people do. Yeah. All right, treating diabetes. Let's talk a little bit about treating diabetes. Well, diabetics were very difficult to treat before insulin was developed in 1922. Between 1915 and 1922, the common way to treat a diabetic, now we're talking about type 1 diabetics primarily here. We're talking about very sick people, primarily children that are dying. They go into diabetic coma. They die. Ketoacidosis. And it's a desperate situation. Well, Dr. Allen, he developed a treatment for type 1, primarily type 1 diabetes, which was a treatment of starvation. The way he developed this is before 1915, he took some dogs and he cut their pancreases partially out and created diabetes by removing this insulin-producing organ. And as a consequence, they became diabetic. And what he found in these dogs, the argument is, was it 2 dogs or 6 dogs or I don't know how many dogs, but it wasn't very many dogs. The consequence is if he took these dogs who were partially removed their pancreas, and he put them on a starvation diet, he could make the elevated blood sugar that was caused by removing the pancreas go down to normal. And he declared this success. And then Dr. Joslin, the famous Joslin Clinic, he became involved in this and supported Dr. Allen's work, and the two of them together started treating severely ill children primarily with starvation diets. I mean, they would literally starve them from 75 pounds down to 45 pounds. And these people were, and many of them died. Oh, very high percentage of these children died. But they declared a success, and that's pretty much where some of our ideas on how to treat a diabetic come from. In other words, restricting calories and putting them on a diet deficient in everything, much less deficient in sugar and carbohydrates, from the basic work of Allen and Joslin. However, Jocelyn wrote something that I think is very important to note, is he wrote in 1927, he says, I believe the chief cause of premature atherosclerosis, you know, that's the bad arteries, and diabetes, say for advancing age, is an excess of fat. An excess of fat in the body, in other words, obesity, an excess of fat in the diet, and an excess of fat in the blood. With an excess of fat, diabetes begins, and from an excess of fat, diabetics die. Formerly of coma and recently of atherosclerosis. And he followed up in the next paragraph by saying it shouldn't be long before we get this all figured out. And in my words, bring sanity to the treatment of diabetes. That was 1927. Here we are 80 years later, and sanity has not occurred. How is a type 2 diabetic treated? Some of you are type 2 diabetics. This is how you're treated. Go to the doctor. Doctor takes a look at you. Type 2 diabetes. Now, not type 1, but type 2 diabetics. Go to the doctor. Doctor takes a look at you and says, hey, George, you got diabetes. It just shot on your blood sugar. And by the way, you're kind of fat. You know, if you lose some weight, your diabetes will go away. Everybody knows your diabetes will go away if you lose some weight. In the meantime, I want to put you on a little insulin or maybe some diabetic pills. Oh, here's a diet for you, too. I got this from one of the drug companies. You follow this, you go home, you follow this diet, you lose some weight. And I want to see you next month. So you come back next month, and George steps up on the scale, and the doctor walks over there and says, hey, you gained 5 pounds in a month. I told you to lose weight. Now you gained 5 pounds, now your diabetes is worse. Now I have to put you on more insulin and medication. Remember, insulin drives fat into fat cells. These medications, most of them drive fat into fat cells because they raise insulin. That's insulin's job, is drive fat into fat cells. Come on back next month. Lose some weight. Your diabetes will go away if you lose some weight. And here's a little bit more medication. See you next month. Come back next month. Now you're fatter and you're sicker and you need more medication. It just goes on and on and on, this vicious cycle. And so diabetics get worse under the treatment of modern medicine. So how do you break that cycle? Well, what I do with my diabetics, my type 2 diabetics, is I stop their medication. 140 units of insulin, 80 units of insulin, a bag full of diabetic pills, I stop it. If I'm sure they're type 1 diabetic. This becomes an issue of judgment, though, because there's a spectrum here. There are people with total insulin insufficiency, like type 1, and then there are people with the insulin excess with this tremendous resistance to insulin activity, type 2. And then there's a spectrum in between, and doctors refer to this as type 1.5. And so, yeah, because there's enough insulin being produced by the pancreas to keep you out of ketoacidosis, from dying, in coma. But there's not enough insulin to make your blood sugar normal. So we call that type 1.5. And for those people, I do have to use some medication. Of course, type 1s always get medication. You understand that? Always get insulin. But there's these people in this spectrum. They make enough insulin to keep them out of serious trouble, but not enough insulin to keep their blood sugars normal, not enough insulin to push fat into fat cells, so they start getting pretty thin. And so when it comes to this intermediate issue, I have to make some other judgments. Instead of taking them all of their medication, which I usually do the first day anyways to find out what's going on, I may sometimes have to put them back on medication. What I use is insulin. I don't use diabetic pills. I use insulin. I use long-acting insulin. It's given in the evening, 1 dose. Even if they're severely diabetic, this is usually adequate. Why do I treat them? Under what circumstances? And what I tell them is, and how I prescribe is if you lose too much weight, I know you laugh, and they laugh too, because some of them are 50 or 100 pounds overweight. If you lose too much weight, then you go on a little insulin to keep that excessive weight loss from continuing. If you develop symptoms of diabetes, such as excessive urination, I'll give you a little insulin to treat that. Or if you worry about the numbers, I run into this all the time. Even though I tell them, blood sugar of 250 ain't that bad. I'm not going to lose any sleep over it, even 350. But that's not the way your mother-in-law feels. That's not the way your doctor feels. Your doctor's told you those sugars got to be much lower. Well, I treat the whole patient. And I treat the worry aspect too. And so sometimes I'll give a little insulin just to make things psychologically much better. Hopefully I do no harm. So if you're a type 2 diabetic and you want to get well, you've got to change the approach you're taking right now. It's not working. You know it's not working because you're still fat and sick. Diabetic management. Diabetic management. Back in 1987, Hockaday, he wrote this statement. He said, it's important to remember that diabetic control means a lot more than blood sugar control. Read that one more time. It means a lot more than blood sugar control. So doctors have been dedicated to making those numbers look better. That's been their full focus of attention. Just get the numbers down. 100 may be normal, lower is better to a point, maybe 70. That's the goal of diabetic management. And so when we've used medications to lower blood sugar levels, we can't do that. We can make sugar low. I can make, any of you in this room, I can give you a blood sugar of 20. I can put you flat on the floor, unconscious. I'm a doctor. Okay, so I can make those blood sugars lower, believe me. So we started treating blood sugar levels, and one of the first ones was with a group of drugs called sulfonylureas. And then they did a university group study, and what they found is over 5 to 8 years, giving these sulfonylureas increased the risk of dying of heart disease by 2.5 times compared to diet alone. And since that publication, back in 1971, every physician's desk reference has included this statement: special warning of increased risk of cardiovascular mortality on all oral glycemic drugs, all pills used to treat diabetes. The only 2 paragraphs in heavy black print in the physician's desk reference under these kinds of medications begin with a special warning: increased risk of killing you from heart disease. That's not changed since 1971. We've done multiple studies. I'm going to show you all the studies, okay? This is what the studies show. Intensive treatment of diabetes causes problems. We start out with a veteran study. The conclusion is they found a strong tendency toward worsening cardiovascular outcomes in patients with intensive control. This was published in 1996. The TRACE study, the largest study ever done in Europe on diabetics. The conclusion is diabetic patients treated with oral hypoglycemic agents or insulin, but not those treated with diet alone, have a significant increased mortality following acute myocardial infarction compared to non-diabetic patients. The ACCORD study, which by the way was stopped 17 months early because of an increased risk of death in the patients. In the ACCORD study, intensive treatment was stopped before the study ended because of a higher mortality in that group. This is the largest study done, the ACCORD study. The ADVANCE study, there were no significant effects of type glucose withdrawal on major cardiovascular events, deaths, or cardiovascular causes or death from any cause. But they did have at least twice the risk of hypoglycemia and excessive weight gain from these treatments. Yeah, when you give these diabetic pills and you give insulin, what happens? You gain weight. Typical diabetic gains about 20 pounds when they're started on therapy. And now we have the veteran study, the most recent study on type 2 diabetes. That's a follow-up of the initial study. The veteran study, intense glucose control, no significant effects on rates of major cardiovascular events, death, or microvascular complications with the exception of protein in the urine, albuminuria. That's the research. It's shameful, but that's the research. If you produce a diabetic pill, you're a pharmaceutical company, you make a diabetic pill, all you have to do is show it lowers blood sugar. You have to show it makes people healthier, feel better, live longer. It just has to lower blood sugar, that's it. Now, after the ACCORD and the ADVANCE study, the FDA tried to impose a further restriction. It's voluntary. And what they said is a non-binding recommendation for the FDA in 2008 said all new drugs developed for the treatment of type 2 diabetes show that they do not increase the risk of cardiovascular events. You would think that was a given, wouldn't you? You would think that in addition to lowering blood sugar, it ought to make your life better. That's not a criteria. They don't even have to do it now. All right, drug management. Yeah, you can lower blood sugar with drugs, certainly, but you have an increased risk of death. You have more heart disease, increased risk of sudden death, a dramatic increase of hypoglycemia, and you gain twice the weight. It's just reflecting back on an experience I had when I was at St. Helena Hospital. At that time, it was the second best cardiovascular surgery hospital in the state of California. And I was under the supervision of other doctors, of course, with my care. And one of the doctors who was head of my health center, he happened to be a gastroenterologist, and he happened to also be a type 1 diabetic. himself. And I remember an experience I had with him. He reviewed my behavior, my professional behavior in terms of my diabetics, and saw that I was taking diabetics off insulin and diabetic pills, and I would allow them to run blood sugars elevated, 250, 350, 150. And they had a big meeting about me. Yes, they did. And we sat down and discussed it. We talked about the research, and I showed that, yeah, you can intensively control blood sugar, but there's no benefits seen. We didn't have all the studies back then. This was dating, probably 20 years ago. We didn't have all the studies then that showed how harmful intensive treatment is. Intensive treatment, by the way, these days is based on lowering something called hemoglobin A1C down to normal, which is 6%. Those who are lower down to normal have the horrible outcomes, as opposed to, say, who run less stringent hemoglobin A1Cs of, say, 7 to 8%. Anyway, this gastroenterologist was quite critical of what I had to do, but at the end of the meeting was, we're not going to do anything about your professional behavior because we can't justify it. Just as a side note, about 3 months later, I heard that he was driving his Lexus. I'm glad it was a Lexus. And he drove it off a cliff. Didn't die, but he had a severe hypoglycemic reaction himself. It's dangerous to be hypoglycemic. It kills. Almost killed this man. So what's the sales pitch? I mean, how do you get doctors and patients to continue to use this drug management when it consistently shows harm? We're not dealing with stupid people here. These are physicians. How do you get them to continue that behavior? Well, the sales pitch is this as well. We don't benefit macrovascular disease like strokes and heart attacks. You know, big blood vessels, macrovascular, but we sure help those people as far as their microvascular disease goes. The little tiny blood vessels, like those little blood vessels that you see in the retina of the eye. See, you look in the back, you just look at a little instrument, you look in the back of the eye, and here you see the back of the eye, and here's a picture. You see all those blood vessels? Yeah, well, you can see changes in those blood vessels. You can see major changes in the eye grounds related to diabetes. And by treating diabetics intensively, more intensively with insulin, maybe diabetic pills, you reduce the complications of microvascular disease, like we call it retinopathy, or damage to the retina, or nephropathy, or damage to the kidneys, or peripheral neuropathy, damage to your peripheral nerves. That's the sales pitch. Does that really hold? Well, there have been multiple studies done, and there's some examples of these studies. The biggest study was one of the biggest was the Accord, and you have the Advanced study. And yeah, some of them show benefits. Yeah, benefits like improvement in photographs of the retina. But most of them, the benefits they show are limited to a reduction in the amount of protein in the urine, albuminuria. That's where the microvascular changes are seen. There's less protein in the urine. But the Accord study just came out. It came out in August. This past month. The Accord study, remember that famous study that the National Heart, Lung, and Blood Institute stopped because it was killing patients? They ended it 17 months early because of the high death rate in those who were intensively treated. They looked at whether or not it reduced microvascular damage, and they said intensive therapy did not reduce the risk of microvascular outcomes. Microvascular benefits of intensive treatment should be weighed against the increase in total and cardiovascular-related mortality, increased weight gain, and high severe risk of hypoglycemia. That's what they said. And a review just came out 2 months ago in the British Medical Journal. The effects of intensive lowering treatment on all-cause mortality, cardiovascular death, and microvascular events of type 2 diabetics. They looked at all the studies. Their conclusion? The harm associated with severe hypoglycemia might counterbalance the potential benefit of intense glucose-lowering treatment. Intense treatment was associated with a significant reduction in only one endpoint, less protein in the urine. Big whoops. Diabetic management. So is diabetic management making the sugar as low and normal as possible? I don't think so, because it doesn't work in terms of what you're looking for, which is a better, longer life. That's been proved beyond any doubt, beyond any contention, beyond any argument, even by the drug companies. Good diabetic control involves doing things like this. Improving the circulation for people. If you feed a high-fat diet to people, what happens is you increase the viscosity of the blood. You cause the platelets and blood cells to aggregate. you reduce the oxygen content of the blood by 20%. Here's what happens after feeding one high-fat meal. This happens to be an animal study, but I'll show you the human studies in just a minute. One high-fat meal, what happens is the blood cells, before the meal, they're hitting, bouncing off each other, repel each other, and the circulation is very good flow. You feed the fat, whether it's animal fat or vegetable fat, what happens is that vegetable fat, what happens is the fat coats the blood cells, they stick together, they clump, they sludge, they cause roulette formation, drop the oxygen content by 20%, cause angina, cerebral vascular problems, thinking problems, endurance problems, all kinds of things. And the flow returns about 8 to 10 hours later. So in essence, what happens is through typical diabetic treatment where you just focus on pills and not on a person's diet, you end up ignoring some of the major issues when it comes to diabetes, such as vascular problems. Here it is in people. This was published twice. In people, what they did in this case is they took, this man represents a fireman, a relatively healthy person. And they set up a design where they look through a microscope and look at the whites of the person's eye, the conjunctiva, and you see on the left frame, you see the conjunctiva before any meal. You see large blood vessels, a large number of blood vessels, which represent excellent circulation. Then they feed this individual one meal that contains 67% fat. In this case, it happens to be animal fat. It happens to be a meal of 2 eggs, 4 strips of bacon, milk, cream, bread, and 2 pats of butter. Any of you ever eaten that before? That used to be what I got up to every morning. One high-fat meal, and what happened is you see the change in circulation occurred 4 hours later, a dramatic reduction in circulation. When they did this with vegetable fat, they found that the impairment of circulation was longer and more severe than it was with animal fat. Kidney disease. The time-honored treatment for people with kidney disease, diabetic or non-diabetic, is a low-protein diet. Dr. Thomas Addis, one of the founders of kidney disease, of nephrology, he said from personal experience that the reduction in renal work by judicious dietary protein restriction was effective in minimizing further kidney loss in patients with diabetes and other chronic forms of kidney disease. What happens is, you got these kidneys, and they're filtering the blood and all the impurities that we put in. When you eat carbohydrate, what happens is the carbohydrate is metabolized into water and carbon dioxide. There's no residue. It's the same thing with fat, carbon dioxide and water. But when you eat protein, you have a residue of nitrogen. And that residue of nitrogen has to be eliminated from the body, and it's eliminated through the kidneys. And there are other issues, like just the protein itself that has to be eliminated from the body when it's taken in excess. And as a consequence of this excess amount of nutrients that the body doesn't need, what happens is the kidneys are overworked. The flow rates and the flow pressures increase in the kidney tubules. And that increase in flow rate and pressure damages the kidneys and sends a person rapidly towards chronic kidney failure and towards the dialysis ward. This has been known for 100 years. So if you're going to treat your diabetics with a low-carb, high-protein diet, their blood sugar may go down, but their kidneys are going to go too. If you're going to treat them with the standard American diet, which is high protein, the same effects. You need to treat the whole body. You need to treat those kidneys. That's microvascular disease treatment at its best. And so what we find are multiple experiments that show us that low-protein diets reduce the progression of kidney disease and death in patients. These are consistent when they use an adequate low-protein diet. There are a lot of people who get in there and just put experimental designs together that are ineffective from the beginning. They can't possibly work. It's like telling you to switch chicken and fish to reduce your chance of dying of heart disease. That's no change that's going to give the kind of results that you're looking for. Later on today, we're going to hear from Dr. Robert Rosati, who manages the rice diet. And I don't want to take away from any of his presentation, but I could not continue this presentation without talking to you about one of my mentors, one of my heroes. And his name was Dr. Walter Kepner. He started the rice diet at Duke University. You'll hear all kinds of things about the rice diet. Dr. Kepner, beginning in 1939 up until it was all well published by 1953, did the same kind of treatments that I do today on people who got the same result. There's nothing I do that's new or original. There are people like this man who paved the way and established the science without any doubt. He took a look at the retinas of patients. And classic diabetic retinopathy, what he found is that aneurysms, punctate hemorrhages, preretinal and venous hemorrhages, waxy exudates, neovascularization, new blood vessel proliferation. What happened is that over a 22-month period on average, 20 out of 44 showed improvements. We're talking about microvascular disease now. We're talking about the reason to give all these diabetic pills is that they may decrease the amount of protein in the urine, and maybe you can massage the studies a little bit and maybe show some improvement in the retinas. Not much, nothing to brag about, unless you happen to be selling drugs. He documented a decrease in heart size, improved kidney function, dramatic reductions in high blood pressure, all that you're going to hear about a little later on today with a dietary change, a rice diet, a starch-based diet. And here, for example, is the retina of one of his patients. You see the exudates, you see the hemorrhages here, okay? Here the person is a couple of years later. Remember, he could document this in half the patients. But his work has never been published in any journal related to our eye disease. Never. And it wasn't just him. It was also Van Eck, one of the people who lived about the same time, showed the same things. A little harder to see, but diabetic retinopathy, you see all the exudates and hemorrhages cleared up on a low-fat diet. This was published in 1958. Yet somehow eye doctors know nothing about this. And who suffers? And cardiovascular problems. You talk about treating diabetics with the same diet that makes the average American sick. You're talking about a person who has metabolic handicaps. A diabetic is an impaired person in the sense you're a diabetic, you get an infection in your toe, you better get it taken care of because you could end up getting gangrene and amputation because your immune system, your reparative processes, they aren't there like in somebody without diabetes. You have a metabolic handicap. Now, what if you take and feed a diabetic the same diet that kills people without diabetes at a rate of 50% from heart disease? What do you think happens to them? They fall apart at a rampant rate. And of course, one of the major killer of diabetics is cardiovascular disease, strokes and heart attacks. A disease that kills people without diabetes, and in this case, when you have diabetes, it's an expected event for you to die early from heart disease. My good friend, Dr. Esselstyn, who's made a lot of press these days, and not only do I applaud him, I am happy to give him all of the spotlight. And he's done an excellent job. I hope you saw him on CNN last week with Bill Clinton, our president. Well, he's shown in his research, he's documented actual reversal artery disease with the kind of diet that you're learning here. It's been shown by multiple investigators. As far as improving cardiovascular outcomes, one of the things we look at was we look at markers, risk factors like cholesterol. I can lower your cholesterol, I'm a doctor. I'll just give you Lipitor. But I can also lower it if I stop feeding you cholesterol, which is found primarily in animal products. And so feeding people a healthy diet, which we've had a chance to do, we're putting together the results of about 2,000 people. We have results of 1,250 from my days at St. Helena Hospital. What we find is that there is a reduction from 219. In 5 days, it drops 15 points on average. That's 1,250 people. And at the end of 11 days, we have a drop of about 30 points in cholesterol. No side effects, no costs, cut your food bill by 40%. There's nothing negative about it. As far as starting with high cholesterol, the average drop is about 29 points. If you start with, say, a low cholesterol, it's a smaller drop, but you get up here in cholesterols of, say, people who have a cholesterol 300 or greater, the drop can be, as on the average it was, 65 points in 11 days. So the sicker you are, the better you're going to get, and the happier you're going to make me. Same thing with triglycerides. These people with triglycerides of over 600, their triglycerides are cut in half in 11 days on a healthy diet. Peripheral neuropathy, there's not a lot of evidence, but there's enough to make me want to change my diet, which has no side effects and tastes good. Work at Weimar, a fellow institution up there a little bit east of Sacramento, in Weimar. They teach a similar diet to what I recommend. And what they reported is that they got complete relief of peripheral neuropathy. That's pain, burning, numbness in the feet. It occurs as a consequence of poor circulation and other metabolic changes of the nerves that make diabetics stay up all night long, suffering. 17 to 21 patients got complete relief of their diabetic neuropathy in 4 to 16 days. I've seen it. So the treatment. Oh, the treatment. Such deprivation. Yeah, the treatment is a starch-based diet. That's what it is. This treatment began many years ago. It began with Hemsworth and Shirley Sweeney with his medical students I talked about in 1927. Rabinovich, he made a big push for healthy eating, and he published his results in 1932. The present status of a high carbohydrate, low calorie diet for the treatment of diabetes. He said, may I, however, observe that we now have over 500 patients on this diet and that 16 failures among them, at least in my opinion, is a highly satisfactory state of affairs. 16 failures in 500 people, he reported in 1932. He made some other statements that I think are worth going over. He said, a potential diabetic can be transformed into a completely diabetic individual merely by administration of time-honored carbohydrate-free diet of meat and fat. He told us that before 1932. Fat protein diets from which carbohydrates are excluded find no logical place in present-day management of a diabetic. The diets are sufficiently attractive so that when given the option of being sufficiently underweight or taking insulin, the majority of patients select the former. Can you believe it? Can you believe that people would rather eat bean burritos and oatmeal and pasta than shoot themselves every day with insulin and die early? Can you believe that? James Anderson, he was head of endocrinology at University of Kentucky during the 1970s and 80s. He took on the chore of taking care of diabetics with a high carbohydrate diet. He found that the average drop in insulin was 26 to 11 units a day. 11 of the 28 lean patients, these are not fat people. This is just a change that occurs as a consequence of changing the fuel, of taking away the insulin paralyzing fat and giving the insulin sensitizing carbohydrate to people. He found that 11 of the 28 lean patients were able to discontinue their insulin. Here's your insulin dosages, your blood sugar levels in a typical patient. Neil Bernard, who's going to speak to us tomorrow morning. Maybe you can get him to say a few words about diabetes. He's going to speak to us tomorrow morning. He also published a randomized controlled trial in diabetes care in 2006 where he actually used some of Mary's help in terms of feeding the people and Mary's recipe books. And we were proud to be able to be part of this study and to help the people with the primary issue, which is compliance. You got to get people to do this, but you got to get them to take pills too. Only half of them will take their pills. So it's a compliance problem wherever you come to. But when they applied reduction in medication, this is a vegan diet, our diet basically, and compared to the ADA diet, and reduction in medication, half of the patients as opposed to the ADA diet, which was about a quarter of the patients. Better drops in hemoglobin A1Cs, which is a long-term measurement of diabetes compared to the ADA diet, twice the weight reduction, and a drop in bad cholesterol, and improvement in urine protein, and so on. So this has been published in a randomized trial in a major medical journal. Some of our patients, this is one of our patients from March 2011, just a few months ago. Came in at 313.4, left 8 days later at 310.2 pounds. Blood sugar when he came in was 152, when he left was 129, and he was on 4 diabetic pills a day, metformin and a sulfonylurea. And he was on Lipitor, cholesterol-lowering medication, and a blood pressure medication. There he was, and I took him off all these medications. In fact, I think it was Dr. Clapper who took him off all these medications. Oh, it's Don? Dr. Forrester took him. That's Dr. Forrester's patient right here. Took care of him in March. And here he is 4 months later, down to 268 on no medication. His blood sugar is normal. Cholesterol went up. Of course it went up. I took him off Lipitor. Here's Robert Cross. Is Robert here? Robert often comes, but Robert's an interesting man to say the least. He worked for the Attorney General's office in the state of California, and at 61 he had high blood pressure, diabetes, high cholesterol, recurrent kidney stones, weighed 250 pounds. His cholesterol, his bad cholesterol was 210, his total cholesterol was 294. Got into trouble, developed some indigestion. Went to the doctor said, no, that's not your stomach, that's your heart. You got angina, sent him to the cardiologist. The cardiologist did a perfusion scan on him in January of 2008. So here we are, January 2008, cholesterol 294. Perfusion scan shows mild to moderate perfusion defects along the inferior lateral walls. What do you think the cardiologist said? Heart surgery. What else is there? Heart surgery. So he recommended heart surgery. Well, you know, Robert Cross, he's works at the Attorney General's office. His job happens to be dealing with doctors. So he decided to get a second opinion. So he went to the internet, he found our website, decided to change his diet, and what happened is cholesterol dropped from 294 to 160, stopped all his medications, by the way. His blood sugar became normal. He lost 60 pounds. Went back to his general doctor. His general doctor was impressed, to say the least. I mean, the numbers are right there, 294 to 160 cholesterol. Guy lost 60 pounds off his blood pressure pills, off his cholesterol pills, off his diabetic medication, normal blood sugar. But the generalist said, you know, we really need to be sure, so you need to go back and see the cardiologist. Cardiologist says, this never happens, couldn't possibly happen. There's no such thing as, and by the way, his indigestion was gone. There's no such thing as improvement of the arteries, reversal of artery disease with a healthy diet. Just can't occur. So the cardiologist insisted on another perfusion scan, so he got another perfusion scan that showed a subtle inferior wall perfusion defect, just a little one. In other words, the previous defects were gone. Unquestionable reversal of atherosclerosis and improvement in circulation. What's the cardiologist's conclusion? Somebody mixed up the tests. John Figler, he's one of our patients. He came to the program in October 2010, so almost a year ago. 372, blood sugar in 130 to 219 range, and his cholesterol was low, his triglycerides were low. He was on insulin. He was on about 100 units of insulin. This is maybe 60 here. On Actos, blood pressure pills, cholesterol-lowering medication, calcium channel blockers to lower his blood. You know, the typical stuff all your friends are on. You know, all your friends, your sister-in-law takes this. That's a well-treated patient. So here he is at the program, October 31st, 2010. And here he is 6 months later. He lost 98 pounds. Blood pressure was pretty darn good. Blood sugars were similar. He was on no medication. This man was just in the last program in August. Drew Powell, 56 years old. Here he is. He happened to be a mayor of a city out in the east, so he's got a lot of nice pictures of him. His weight was 276. He was on a combination of metformin and I think that's a sulfonylurea. Blood sugar is in the 200 plus range. Hemoglobin A1C of 9. Remember, it's supposed to be 6%. This is 9. So he changed his diet. Here it is in the beginning of May. His blood sugar is up around 320, 340. Changed his diet, stopped his diabetic medication, and these are his blood sugars since. You see, when I take care of these type 2 diabetics that come to my office, I have to act quickly. And so the first night I see them, on Friday night, I ask all the diabetics to come up and talk to me. I can't wait until we have our visit together. I have to talk to you that night because if I don't, you could run a low blood sugar, you could fall over in your mashed potatoes the next day. So major reductions have to be made immediately. Now I have the luxury of making mistakes. Doesn't happen often, but I'm right there to take care of the people. So if that recommendation was not wise, I can make another recommendation a few hours later, or another one a few hours after that. But rarely does that become the case. Most patients, when they reduce their insulin or stop it, they're off of it, or other reductions are required. Here he is in last month, what was that? It was a few days ago. He's down 30 pounds on no medication. Hemoglobin A1C is almost in half. You should expect this. This is not the best case scenario. You should expect this. And it's all from a starch-based diet, the traditional diet consumed by people throughout all of human history. Even today, when you look in parts of the world where people eat a starch-based diet, you know all that rice that turns to sugar that makes you fat and diabetic? You don't find any diabetes. It's virtually unknown in these populations of people to have type 2 diabetes. Type 1 is quite rare too. Virtually unknown. Yet these people in China and Japan and Thailand and Africa who are learning the Western diet, they develop this disease almost overnight. when they give up that rice and the corn and the beans and switch to the meat and the butter and the cheese. This is no mystery. We know it causes type 2 diabetes. We also know the cure. It's a starch-based diet, which is the human diet. You are a starch eater, or in better terms, you are a starchivore. Thank you. All right. So I have to answer. I've got 5 minutes. I'll be happy to answer any of your questions. Yes. Could you come over here, Jack?
Sure. As I know you know, one of the controversies in good nutrition is not whether vegetable oils are good for you, but whether nuts are good for you with their fats. And the BART study that one of our subsequent speakers did showed that walnuts indeed were good for vascular function. Has that been done with the microvascular studies in the eye?
These are free oils that we're talking about, not the oils that are in food. And that's a big difference. When the oil is ripped out of the nut, you're no longer dealing with a food any more than just stripping the protein or a vitamin out of a plant. This is no longer a food. This is a medicine at best and at worst a serious toxin. So people confuse free oils, which I always recommend you avoid, and high-fat plant foods, which some of you can eat with little concern. Some of you are thin, some of you are healthy, some of you need extra energy. I don't see a problem with eating, in fact, you probably will serve you these here. Some avocados, some nuts and seeds and olives. Those are whole, healthy plant foods, but they are rich. That's why avocados only come in season for 2 weeks out of the year. Unless, of course, you shop at Whole Foods. And that's why they put nuts in hard shells. And of course, coconuts are almost unopenable because they're so rich. So I don't see them as unhealthy foods. They're just rich foods. And as far as improvement in vascular health by switching to nuts, it may be, but as opposed to what? As opposed to bacon? I mean, did they take the bacon away and put nuts in? What were the changes that took place?
On the BART study, they compared your baseline with certain oils, and they compared it with salmon, they compared it with canola, with olive, and as you might expect with the olive oil, it was the worst, degradation in function. With the canola, it was moderately worse. With salmon, it was very little change. It was a tiny bit worse. But with walnuts, real walnuts, it was significantly better vascular function.
Well,
it wasn't just stable, it was better.
If I hear what you're saying, compared to free oils, I would absolutely expect that. But I don't know.
It wasn't compared. It was compared to baseline with with nothing. So it actually improved your baseline vascular function.
Well, I had some folks, and this may be related to the study you're talking about. I had some folks from Loma Linda on my television show one day. They talked. Their studies were actually funded by the almond industry, but I think their studies were true. They showed that adding almonds to the diet could be of help to people in general. What I told them is I don't think people should make the mistake of thinking the solution to health problems and weight is to add almonds to your bacon and eggs, which unfortunately is the way people think. Oh, now I have the answer. I'll just add a few extra almonds and that'll counteract all of the negative things I've done to myself. I'm sure this study is not only true but important, Jack. Yes?
Since the questioner asked about the study that I did, we're going to talk about next time, and I appreciate the segue. We'll just keep your interest for 15 minutes, and we're going to talk about some of these things.
Good. I'm sure we have a lot to learn.
Dr. McDougall, how do vegetable proteins affect the kidneys? If we overeat?
They're less unkind to the kidneys.
Yes.
In other words, when you put people on low protein diets, and this research is published, as a matter of fact, if you go to my website You look under hot topics, kidney disease, there's an article on diet and kidney disease. The references for this research are there, and they look at the difference in the effect of equal amounts of vegetable and animal protein. Animal protein is much more burdensome on the kidneys and the liver compared to vegetable, but you want to decrease all protein. So when I take care of a kidney patient, I limit their beans, peas, lentils, and other high protein foods, because that's extra work on the kidneys for this protein load. But they are kinder. Plant proteins are kinder, and that's been well established.
So we don't have to worry about it.
Oh, as far as if you're in general health with good kidneys, we're talking about the effect. What happens is this, is the average person who's in average good health, they lose about 1/3 of their kidney function by the time they get to be 70 because of the wear and tear of the typical American diet. But 1/3 of your kidney function is not a big deal. You only need 1/3 of your kidney function to metabolize all of the waste. So if you lose 1/3, so now you got 2/3 left, you only need 1/3 to clear all the waste, you never see the effects. But you take somebody who's lost part of their kidney, say they have donated a kidney, or they got in an auto accident, or they have diabetes, or an infection, and now they're down to 30–40% of the kidney function that would be normal. You feed them a high protein diet, that hurries the kidney loss and pushes them rapidly to kidney failure in a dialysis machine. So it's really critical in people who've lost any kidney mass at all. The general person has so much reserve, it does not become an apparent issue, but it is there.
Thank you.
But as far as high protein, I've generally recommended 1 cup of cooked legumes a day is sufficient. I don't think you should, and I do that because I don't think people should have beans, peas, and lentils 3 times a day. It's a lot of protein. That's 30% protein. Yes?
Yes, so I'm a critical care nurse, and I understand type 1, type 2 diabetes. But as we see patients coming into critical care or any hospital with an acute illness, we see their sugars rise. And so hence, we're on the push for tight glycemic control. And I'm wondering how your thought is on that.
This is a little bit off topic, and I really have to familiarize myself with the research again to give you a more definite answer, but I will give you a definite answer.
Okay.
Because this has been published, this has been reviewed. Intensive treatment of critically ill people with the intention of lowering the blood sugar has been shown to increase the risk of death and poor outcomes. Okay. Right, Craig? He says right, so it's right.
Okay. All right, thank you.
And this has been looked at, and the research is, as far as I remember, is consistent and clear. This is bad professional behavior to have that aggressive treatment going on. But again, it's off topic, and I would have to review again to give you the specifics.
All right, thank you.
Okay, well, we got 2 more quick questions.
Dr. McDougall, if you could just comment a little bit about potatoes and type 2 diabetics, especially white potatoes. There's this information that you can vary glycemic index by cooking method,
Right.
and so on. So can type 2 diabetics eat white potatoes or not? Because there's a lack of consensus in the community about that.
Well, there's a lot of rumor. There's a lot of rumor about how bad potatoes are. I'm Irish. You know, potatoes have served as the pillars of worldwide nutrition throughout all of human history. Potatoes have made the difference as to whether populations survived or perished. Potatoes are an ideal human food, as was discussed last night. Potatoes make diabetics better, not worse, for a whole bunch of long-term and short-term reasons. You want to talk about weight loss, you go on an all-potato diet. The guy who did it last year, remember that? Guy from, I think it was Washington, decided he was going to not put up with this potato bashing anymore. Went on an all-potato diet for 2 months and lost 30 pounds, dropped his cholesterol, blood pressure, etc. He thought that was new. Actually, the study that was originally done that I'm aware of was published in 1928, where they took a man and a woman, age 25-year-old man, 28-year-old woman, put them on an all-potato diet for 6 months. And not only did they say at the end of the paper, you can look it up, it was by Kahn, in the Journal of Biochemistry, 1928. Not only did they like the diet, they said clearly at the end of the paper that they did not tire of the all-potato diet, but they were in excellent health from eating an all-potato diet. So this is misinformation. This is the kind of thinking that guarantees all diabetics will remain diabetic. You will never get better believing what everybody knows to be right. It's wrong. Last question.
Yes, I know you watched the show, the CNN show last week, and I was wondering what Dr. Agustin was talking about when he referred to the really small lipid particles cause more damage than the not as small ones?
You know, I wish I had the time to go into the question. Just to give you the brief answer is doctors try and micronize everything possible. And of course, patients like to have this type of analysis done. So what happens, you go to the doctor, your cholesterol is 280. And you go, oh, this is terrible. The doctor says, oh, it's not so bad. Your good cholesterol is high. Oh, thank goodness, I keep eating what I've always eaten. Well, your good cholesterol really isn't high, but let's look at your particle size. Maybe we can give you another out. You know, it just goes on and on and on. Yes, there's some relationships, but they're irrelevant because the same diet that lowers your total cholesterol improves all aspects of cardiovascular health. And to take a look at these various small particle sizes and fractions of cholesterol, et cetera, may serve the business well, but it doesn't serve the patient well. And I'm sorry I can't go into more detail than that. Well, thank you very much. I enjoyed giving this presentation, and I appreciate your feedback. Thank you. We're going to take a 10-minute break.